Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. I think we can still say Happy New Year. I enjoy saying it well into the month. So Happy New Year to all of you who are watching and listening to GLI Live and are part of the larger liver health family. My name is Donna Cryer. I'm the founder and CEO of the Global Liver Institute and your host for this episode of GLI Live. I have with me a very special guest whom I'm sure many of you are familiar with in his role as chief of the Division of Hepatology and professor at Northwell Health. But he is also treasurer of the Empire Liver Foundation, which is a community service organization that is part of the GLI Liver Action Network. And it is in both of these roles that I welcome Dr. Bernstein, and I'm excited about having this conversation.
Thank you, Donna. Thank you, everyone. If I can just correct, I'm no longer the chief at Northwell. I stepped down and retired from that part of my life in July of 2022. So I'm
things are ever
active
evolving.
in other things, continue with the Empire Liver Foundation and lots of others, but that part is in the past.
And this is why live television is always fantastic and fun, and why one of the things that I've signed up for in 2023 formally, and I'm going to see if it's something that we roll out throughout GLI as a whole, is improv classes. So I am taking improv classes for just such times as these. So this is exciting for me to learn, because that means hopefully you'll have more time to spend with us on the Empire Liver Foundation side.
Nice, yes.
So tell us about the foundation, who started it, why it started, what it does.
So the Empire Liver Foundation really was born out of an idea from Dr. Ira Jacobson, who's a very prominent hepatologist in New York. And his idea was to get liver doctors together several times a year in an informal setting, usually over a meal or, not, to do two things: to discuss interesting aspects of liver disease, to find out what people are doing, in other places within New York, and then figure out how we could potentially all sort of work together, learn from each other, and say, we have a bunch of these liver specialists in New York, and instead of working in silos, we should all begin to work together to benefit the patients down the road. And we did that for a little bit, and then, as you can imagine, we ran into the one hurdle that one always runs into when you're trying to do these things, and that's, how do you finance this? How do you keep this moving? And so he spoke to me and Doug Dietrich and some others, and we decided that we were going to try to fulfill a need that we saw in the New York and the tri-state area. Mm-hmm. Is, how do we get all these liver doctors together in a way that there isn't any outside influence, that is away from all of their institutions, where they can really brainstorm and figure out how to improve what they're doing and how to help local communities. And so we put together this foundation. At this point, it's perhaps 7 or 8 years ago. Mm-hmm. And that foundation had two main goals. The first was to distribute knowledge downstream to local communities by creating local experts. When what we didn't want to do was say, we have these big experts in New York, and they're going to go be the experts in the communities, because that doesn't make sense.
Mhm.
We recognized that we think was a need for local folks to have local experts who can care for the patients in their communities, because everything is local. So we set up this educational process, by which we got liver doctors from almost all of the hospitals and academic centers in the lower portion of New York and New Jersey, and to some respects, Connecticut and some counties north of New York,
Mhm.
and came up with educational programs together, sent those folks into their community to meet with local doctors in various settings. And then those local doctors could then use those local experts for calling for questions
Mhm.
about patients. And it clicked. And the second thing that we did is we decided that, as you're well aware, advocacy for patients with liver disease is so important. And
Mhm.
this sort of developed at the time when hepatitis C treatments were just beginning, some of the newer therapies. But there
Mhm.
were coverage issues, and there was disparities in who could get them. And so we decided that the other main goal of the Empire Liver Foundation would be to influence public policy in New York. And we rapidly became the go-to organization for both the New York State and the New York City Department of Health, because in New York State, those two Department of Health are actually separate.
Right.
And it worked. And that actually led to uh, significant support from the New York City Council, whereas they give us grants for education to do exactly what I had described over the years, to go into all of the different communities of New York City to educate. And so we work incredibly closely to this day with staffs from the New York City Department of Health. And so that's really, and it's been very successful. We still get together
Mhm.
from Ira Jacobson's brilliant idea of collegiality and cooperation.
Mhm.
So we still meet 5 to 6 times a year. Uh, Obviously, it's been a little difficult through the COVID era. Now we're getting, back to in person, because we really believe that we're a family of people who care for folks with liver disease. And if we all know each other when we work together, we can then bring that down to the communities, because at the end of the day, this is about patients. Right? It's about getting the information to the primary care doctors who care for the patient, so that the patients can really benefit. Because, as you know, there's such there are so many misconceptions regarding liver disease in the community. There are so many patients who need care who just don't get it, because there's a lack of understanding of what they have, and where they should go and what's needed. So we're trying to bridge that gap.
And you were ahead of the curve in doing that, and so I really thank you. And I want to go a little deeper into both aspects. So
Yeah.
I first became aware of the Empire Liver Foundation through our founding board member Hillel Tobias, and so knew of your great work with Dr. Jacobson and others, and just thought that I was so impressed, because you all do so much just in your day jobs, or in your former day job, of treating patients, and making sure that patients got connected to the right types of care, and were navigating things in your New York practices. And to me, that's quite heroic in and of itself. And the fact that you wanted to take this very important step of ensuring that patients actually reached you, so that the connections between primary care and gastroenterology to hepatology that we see particularly in fatty liver disease and NASH are just really been not happening, and need to, with great urgency. And so models of the type of relationship building across specialties as you have are so important to lift up, so that we can really rapidly replicate and scale those. Is so important to have done. And then on the advocacy front, GLI often, I think, people don't quite understand what we do because it's often in that policy and advocacy world where it all seems like sort of either magic or mischief, depending on what side of the issue that you're on. But it is a very long time framed, very consistent and persistent process of pulling together data, putting together information, marrying that with human stories, both patient and physician, finding the right, person on the right committee, and moving often multiple times until you get something passed. And so the fact that you understand that that persistent and that time frame and can communicate that to the other advocates within the Liver Action Network is very helpful, because I think often particularly patients and families that are affected by liver disease, they come in and they want to change something, really fast, something in the system, upset them, nearly killed them in some cases, and they want it to change really fast. And so I think having the arc of your experience in both policy and clinical change is really helpful to sort of set the tone and the pace for the Liver Action Network as a whole. So I've been very grateful for your participation.
Well, thank you. We're really excited to be a part of the Liver Action Network because what we've done in New York is to try to create a family, but it's if we can expand that nationally, I think it's better. To put my career in perspective, if you will.
Mm-hmm.
So I started doing this about 30 years ago. There were no treatments for any liver disease. And so it was this really vital organ that we didn't really understand, that had all of these different diseases that we could diagnose but couldn't treat. And, over the years, we developed curative treatments for hepatitis C, suppressive treatments for hepatitis B, wonderful treatments for primary biliary, cholangitis. We're on the cusp of treatments that will be approved for fatty liver, right? Transplantation 30 years ago had poor survival. Now it's phenomenal, right? But we can't have the phenomenal transplants without people understanding the importance of donation.
Right.
And so for us, it's much more than getting information so that we get, referrals to the specialists. I think we at the Empire Liver Foundation firmly believe that a significant portion of liver disease can be cared for by the primary care docs in their communities if they understand the liver disease, and if they just have someone they can contact who's an expert if they have a simple question before having send. Because we know we lose patients, right? They feel very comfortable with their primary doctors. But once they start having to go to specialists, it becomes more difficult for them. And so if healthcare isn't easily accessible for patients who feel comfortable with the folks that they know, they're not going to benefit. So education locally is so important. And we've been lucky in New York because our legislators, both city and state, have sort of understood that, right? Because also from a understanding, those local people vote. So if legislators know that they're having a positive impact, it's a win-win for all, and they have. And so we're excited in what we've been able to accomplish, but we're just scratching the surface. And there's still so much more to do.
So since you are so experienced in creating bridges to primary care and helping hopefully get them excited about the liver, what are some of the challenges that primary care and other sort of non-hepatology physicians find in diagnosing and treating liver patients well?
I think there are a couple of things. The first is that, primary care physicians are so busy and they're responsible for everything.
Right.
And the way the system has been set up is if someone is sick, initially that's where they go. And so they're so busy with caring for the acutely ill. sore throat, shortness of breath,
Mm-hmm.
fevers, whatever, uh, that it's much more difficult to then say, I have identified someone with a chronic disease. How do I intervene? I think the best example where we've made some successes is hepatitis C, right?
Mm-hmm.
Hepatitis C, as you know, is a virus that affects the liver. It's extraordinarily common. Most people feel fine, don't have any symptoms, but it can lead to cirrhosis, liver cancer, and the need for liver transplantation. We went through a period where therapies were horrendous. And still, even though it's quite common, each individual practice doesn't have very many patients per se, right?
Mm-hmm.
And so there's a problem of identification. So we, with the support of the New York State legislature, were the first in the nation first in the nation state to pass a law, have a law passed, which mandated the offering of screening, for the baby boomers, those people born
Right.
between 1945 and 1965 in the primary care setting. That meant identification. But even with that, and there was significant uptake in testing, how do you get those patients to treatment? Then you had to explain that there are these therapies that are now 8 or 12 weeks, 1 to 3 pills a day, almost no side effects, 99%
Right.
cure. So it took time, but we've almost gotten there, where we've passed the torch of teaching and treating to the primary care, because nothing makes a primary care doctor happier than actually having success,
Having
right?
some.
And treating and curing someone, and patients are so incredibly thankful because they just didn't know. Uh, and so that's just sort of an example. And so we have to educate the primary care doctors regarding the disease states, uh, allow them over time to take ownership once
Mm-hmm.
therapies become available, and intervene so that they feel positive about what they're doing, because the patients, will. The biggest challenge we're going to have upcoming is explaining the problem of fatty liver disease, which we know now is the most common liver disease in the US. 1 in 3 people have fatty liver disease. It particularly affects children, teenagers, and people in their 20s who we know are going to develop liver disease in the future, and diabetes and heart disease. But the initial therapies are going to start with the primary care people. But it's a new disease. So when I first started doing this a couple of decades ago, fatty liver essentially didn't exist. And now all of a sudden, we realize that it's here. So the challenge for the primary care people are to learn about these diseases, and then decide how to intervene. Who do you refer, right?
Right.
It's probably 80% of people with fatty liver disease don't need to leave the primary care doctors,
Mm-hmm.
but they do need intervention as regards to nutrition advice and other things. And as always in the changes of medicine, which have not been positive over the years, unfortunately, it's all about time. Physicians need time to spend with the patients so that they can counsel them and develop that relationships. But the way reimbursement has changed, the way the electronic medical records have changed, it's taken the primary care doctors away from the face-to-face, more to the back-end paperwork, which I'm sure almost every primary care doctor will say has hurt their ability to develop the relationships. So that, I think, is probably their biggest challenge. How do you change that? How do you empower the doctor to be able to spend the time? Because it's all human nature. If you spend the time and you talk to someone and you develop that relationship, they're more likely to pay attention, listen, and know you're there. And how do we change the system so that the primary
Mm-hmm.
care doctors can do what they're trained to do?
I think that is a huge
Yes.
challenge. And I think it's also, how can we make sure that they are, supported across their team with nurse practitioners and others, because I often feel people say, well, have the doctor do it, have the doctor do it. And it's not always the person with the MD who needs to be, given all these additional responsibilities. It's really perhaps a whole team. And if we, can make sure that there is sort of a full set of staffing, all the way to community health workers. And we've talked about how to augment with digital health ambassadors, to teach everything from, how you access your portals to, to connect in different ways. I think if we think more holistically about the healthcare workforce to be able to support the physician in all the things that we've now sort of loaded up on his or her plate, everyone will be better served, because I am very concerned about, burnout of physicians and the impact, as you said, of issues like, having only small amounts of time, the undervaluing of cognitive services, which we need, and if you're a complex patient, rather than procedures. The fact that we keep talking about, Medicare physician cuts, even though I don't know any cost in a doctor's office that has gone down or will go down in the next year. So I don't know why we persist in talking about Medicare cuts. That issue should be just off the table. And so I think that there are definitely some of these larger issues we've worked on, waivers of a lot of prior authorization and things that do bog down the back offices of practices so that they can spend more time with people. I think all of those things are important. And when we talk about what are liver health policies, it is more specific than or is broader than just getting reimbursement for a specific treatment. It really is about making sure that the healthcare system can adequately and appropriately care for liver patients and their families in the ways that we know are optimal.
I couldn't agree with you more in everything that you said. And I just want to reemphasize something that you mentioned that is so important. And first of all, that the care for liver patients is really a team. Yes, there's a team leader, but everyone has an equal and important part. And the nurse practitioners and the physician assistants who are part of that are so critical. And they do such an amazing job, in caring for patients. And then the other group that is so critical to the care of patients with liver disease is actually a clinical pharmacist. About, at this point, 7 or 8 years ago, we brought on a clinical pharmacist into our practice. And it made such a difference in the way we were able to care for patients. And our patient satisfaction was so much greater because, the pharmacist spent time with the patients going over the medications that they're taking. Something that we don't have the time to do, but it's so critically important. How do you take it? What are the side effects? How do you manage those side effects? How are potentially those medications interacting with the other medications that you're taking? How do you get the medicine? Since it's a complex process in liver conditions to go through insurance and the prior authorizations to get medicines, and so many patients, especially in the underserved areas, give up, right? Which means they don't. So having that, and so I don't know how I practiced medicine in the past without a pharmacist available. Patients are, it made such a difference. So it really is a team of all, and I don't want to leave out the nurses, the people who answer the phone, the medical assistants, everyone coming together to come. But as you say, how do you put that team together and ensure that that team can care for people? And that's where we need the policymakers, because at the end of the day, there should be some metric on a true outcome. Patients getting better, right? Patients taking their medications, not some of the other metrics that are being used. Because at the end of the day, it should be about preventive care and not being reactive, but being proactive. And how do legislators and how do we advocate to get the support to do that? Nutrition, critical.
I think that is those are great examples of ways that the patients and caregivers who are coming through our Advanced Advocacy Academy and partnering with the community organizations in the Liver Action Network can play these often unseen roles in creating and aligning quality measures. I know I chair several initiatives and quality measures, and was speaking with a hospital the other day about how to make sure that all of these efforts around quality measures, either in liver health or in equity, are aligned so that they're not at cross purposes and they're not overburdening the health system, so that we can actually get to things that are meaningful, and not just sort of paperwork or checking the boxes and things like that. And I think patients have a great role in those discussions, because we're so practical and we are so focused on, well, did the person get well, rather than the various processes. And so it's been exciting to work and support liver health advocates to be in those types of situations as well. And I where we previously were not, and then measures would come out and they would bear no resemblance to what we really needed, or what we would have defined as people who are living with this, both from the physician and the patient side, as what are the actual elements of care that lead to somebody being healthier. So it's been excited to partner in those new ways.
Well, we really need you to keep doing that. Thank you for all that you are doing, because we can't do it alone. It is everyone together. But patient advocates like yourself, know the journey, can really point out things that others don't know. And even the healthcare providers, far more about what it takes to get the care you need than we do. And so your work is so valuable. And if we, as part of the Empire Liver Foundation, and I'm sure individually, folks who are members can help in any way, we're here to support you and work together, because what you're doing is so important on the national level. But don't forget that things are local. So we do need, boots on the ground in all 50 states, trying to change things to help patients. Unfortunately, we don't have a national health policy. We have 50 different ones.
Right.
And so we have to really be able to influence in all areas.
I agree. I think that's the exciting opportunity of the Liver Action Network to be getting information from the states, from regional health plans and issues, and being able to make sure that as we're proposing national policy, it is informed, but also how national policy may play out. I remember at one point in my career going from working on things with the Senate Finance Committee. And then on Monday, I had a different job, and I was at a hospital in Texas. And I was like, oh, what we just decided we're talking about on Friday is not going to work here on the front lines of healthcare at this system. And ever since then, I've recognized that those levels needed to be talking to each other. And I think there's the opportunity in 2023 with the Liver Action Network. Last year we were able to give out almost $100,000 in community grants for education events, for screenings. We hope to more than double that this year to support people's efforts, in addition to the policy exchanges. And we also look forward to filling in some of the geographic gaps, so that there are patients and community physicians who are connected to the organization and to the land, no matter where they reside, so that we have a full complement of insights and issues from the different states. So I'm very excited about 2023, and I've been so excited to have you as a part, and to always to learn and listen, to be better, because that's always my goal, to grow.
I agree. I think 2023 should be very exciting, especially with the likelihood of new, novel, first-in-class approved treatments for fatty liver disease. But as you just said, Donna, it's about getting that education out there. and about doing the screenings and things that your organization can do that really others can't. And so I'll put in a plug for you. I mean, I think it's so important for the folks out there listening, because none of this can be done without funding. Yes, you're giving out all this money, and that's phenomenal, but it's got to come from somewhere.
Yes, thank you for pointing that out.
It needs to come from governmental sources, non-governmental sources, others, to realize that what you're doing is representing people with all sorts of liver disease, not just one. And by educating about underlying liver diseases, everybody benefits, because patients will then get the appropriate care they need for the condition that they have. But it starts with education and screening and understanding. And so I hope that you're able to raise the funds that you need to do that, because it's so critically important. And I hope all the different parties that have interest in a particular disease come together to support you, to realize that we're greater as a whole than separate. And that
From
may
your mouth
help
to God's ear.
overcome some of the misconceptions that are in the communities about various types of liver disease.
Amen. I can't say it any better than that. Thank you, Dr. Bernstein.
Thank you for all that you do. It's been a pleasure.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.